Good morning and welcome back to Journal Club. It is so great to be back after a 2-month hiatus, and we hope no further disruption to the schedule. Before we begin, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I will say welcome again to those who are just signing on. Welcome back to Journal Club. It's great to see everyone here this morning. We have 2 exciting presentations from PGY4 subspecialty geriatric medicine residents this morning. Please remember to keep your microphones on mute. We encourage you to add comments to the chat box, and there will be time for questions after each presentation. To start, Dr. Rameez Imtiaz, PGY4, to review a trial of a drug you may be seeing more frequently. The comparison of Lemborexant with placebo and Zolpidem for the treatment of older adults with insomnia disorder. Rameez, please feel free to share your slides and begin.
Sure. So I echo Dr. Gendel. Nice to see everyone. So we'll get started right away. So like Dr. Gendel mentioned, this is a trial that was published in 2019, and it was the initial trial that led to eventual then approval of Lemborexant, and that's why you may be seeing it in some of your clinical practice today. I have no conflict of interest. The objectives are we will introduce the orexin system, which I think is important for us to understand if we're going to understand the premise of the trial. We'll then move into the review of the trial and finally a critical appraisal and some questions at the end. So what are orexins? So orexins are a group of neuropeptides produced in the hypothalamus by a small subset of neurons. A lot of the research on orexin actually stems from studies on patients who had narcolepsy type 1. And what we find is that these are molecules that are transmitted by the hypothalamus and act on postsynaptic receptors and regulate the wake and sleep cycle. In the waking hours, orexin concentration is at its highest. And as we get towards bedtime or sleep time, orexin concentration and activity decreases, which is a signal to our brain, along with other things like melatonin release, that it is now time to go to sleep. And in patients who have narcolepsy type 1, they have a 80 to 90% reduction in this nervous system tissue. And it is believed that that is one of the reasons why they experience this condition. Lemborexant is essentially a competitive inhibitor of the postsynaptic receptors for orexin. And so the idea is that by taking this medication close to bedtime, you have further reduction in the orexin activity, which then promotes you to go to sleep and remain asleep for a longer period of time. This was a phase 3 trial, again, like I mentioned, conducted in 2019 on the back of successful phase 1 and 2 trials. And what it was a randomized, double-blinded, placebo-controlled study looking at Lemborexant and comparing it both with Zolpidem extended release as well as placebo. Important to also keep in mind that this was a pharmaceutical company sponsored trial. So Eisai is a publicly traded pharmaceutical company, and they were responsible for sponsoring this trial. It was conducted across 67 sites across North America and Europe. And although data was collected from site investigators at each of these 67 sites, it was then sent back to Eisai, where it was analyzed by their statisticians and then distributed to these authors you see here for further interpretation and manuscript development. If you go on the Eisai website, you'll see that they heavily promote one of their drugs called Devigo, which is the trademark name for Lemborexant. So the inclusion criteria of this study involved women over the age of 55 and men over the age of 65. It's not quite clear to me from reading the protocol why 2 separate age groups were chosen, but what is clear is we'll see shortly that it does have a impact on the type of patient population they eventually ended up recruiting. These patients must have had an insomnia disorder as classified by DSM-5, and they must have had both subjective wake after sleep onset, i.e. a feeling of waking up after they had gone to sleep, and they must have evidence of that on polysomnography of sleep maintenance insomnia. They must spend a regular amount of time in bed, and their insomnia severity index, which we'll see on the next slide, is a scale used to rate the severity of insomnia, must be 13 or greater. The way they determined all of these inclusion criteria was through clinical histories, through sleep diaries that these patients kept, and also looking at polysomnography for evidence of sleep maintenance insomnia. Interestingly, patients did not necessarily need to have sleep onset difficulties to be included in the trial. And I say interestingly because their primary endpoint was reducing sleep onset time. So on the left-hand side here, we have the insomnia severity index. Again, just a series of questions that look at how challenging your insomnia is, how much it interferes with your life, how noticeable it is to others, etc. So they used a cutoff at least 13 or greater. And on the right-hand side, we have the DSM-5 criteria for insomnia disorder, which is actually captured pretty well in the inclusion criteria. So this was the study design. It was a study that was conducted over a 2-month period. The first 2 weeks were essentially a trial week where all patients took a placebo pill. The idea was to get patients in the routine of taking a medication at night before bedtime, and also keeping an electronic diary within 1 hour of waking. The next 4 weeks were the actual treatment period, where participants were randomized into 4 separate groups. Group 1 was placebo. Group 2 was Zolpidem, 6.25 milligrams. Group 3 and 4 were both the Lemborexant group at the 5 and 10 milligram concentrations. These groups were not equal. They were in a proportion of 5 to 5 to 5 to 4. The final 2 weeks was a washout phase where none of the patients took any of the medications. And finally, after the study was complete, there was determination of withdrawal symptoms as well. Over the course of this entire study, there was ongoing monitoring for treatment emergent adverse events. These were any adverse events that occurred over the course of the study period. And then it was up to the researchers to determine if it was related to the treatment or not. And so this was done through clinical visits, and we're not given a lot of information on how frequent these were, but clinical visits that looked at things like vitals, weights, blood work, and urine studies. In terms of the endpoints, this is a bit of a busier slide. In terms of the endpoints, really it could be divided into 4 separate endpoints that they were looking at. Their primary endpoint was Lemborexant more successful at reducing latency to persistent sleep, which they defined as minutes from lights off to the first epoch of 20 consecutive 30-second epochs of non-wakefulness. This was measured through polysomnography, and the means on days 1 and 2 were compared to the means on days 29 and 30 of the study. And this is the treatment period. In terms of the secondary endpoints, there were both objective secondary endpoints and subjective secondary endpoints. The objective secondary endpoints were firstly sleep efficiency. So this was the proportion of time spent asleep per time in bed, again measured by polysomnography. And then there was also minutes of wakefulness from latency persistent sleep until lights on. So i.e., were these patients waking up after they had gone to sleep, and how long were they waking up for? And they also looked at, were they waking up in the second half of the night, primarily because most sleep studies have shown that patients who wake up after having fallen asleep do so predominantly in the second half of the night, not the first half. This was again compared means from polysomnography at days 1 and 2 to days 29 and 30. The secondary subjective readings were the electronic diaries that patients were keeping, and they looked at things like subjective sleep onset latency, subjective sleep efficacy. Again, the definitions were the same, but patients were just asked to rate how they thought they did. And finally, subjective wake after sleep onset. And for this, they looked at means in the electronic diaries from the first 7 nights and compared it to the last 7 nights. And finally, the tertiary endpoints looked at adverse events, looked at changes from baseline insomnia severity index, and also looked at withdrawal symptoms as measured by the Trier benzodiazepine withdrawal symptom questionnaire, which, like the name implies, is designed for benzodiazepines, but was used for this trial as well. So this is how the results ended up shaping out. A total of 3,500 patients were assessed for eligibility, of which 2,500 were excluded. Many of the, or most of the excluded patients did not meet the eligibility criteria. So I have not included the exclusion criteria just for time constraints, but some of the exclusion criteria makes perfect sense. So these are patients who could not have a primary sleep disorder, like obstructive sleep apnea, for example. But there were a lot of subjective criteria as well. So for example, if the investigators felt that patients had too much caffeine, they were not included in this trial. Or if they felt that they had any medical or psychiatric illness that would interfere with their sleep, they were not included in this trial. And so it's just important to be aware of as we analyze the results. A total of 1,000 patients, approximately 1,000 patients were randomized in the placebo, Zolpidem, Lemborexant groups. Majority of the patients, almost all the patients, got some type of safety analysis at some point in the study. And the vast majority of discontinuations were in the Zolpidem group, of which 6 had experienced some sort of adverse events for the reason they discontinued. In the other groups, there were lesser discontinuations. In terms of the baseline characteristics of the patient population, although age was quite similar across the different groups, because of that inclusion criteria of females over 55 and men over age of 65, the vast majority of patients ended up being females, up to 85%. And the vast majority of patients, again, in a North American and European trial, were Caucasian and Black, and there was not a lot of capturing of other minorities. Again, most of the waking periods that were happening after sleep onset were in the second half of the sleep as opposed to the first half. In terms of the results, the first result here is the mean change from baseline in latency to persistent sleep. What they found was that there was a statistically significant difference, both in the Lemborexant 5 and 10 group when compared to Zolpidem and placebo. And it was approximately a difference of -20 minutes, which is quite significant because if you go on the previous graph, we'll see that patients on average took about 40 to 45 minutes to go into persistent sleep. And so you're essentially halving that with the Lemborexant group. In the Zolpidem group, there was a leveling off. And at day 29 and 30, it was actually comparable to placebo. And this was not the case with the Lemborexant group. In the next graph here, we see the least square mean. And this is a statistic that was used because the proportion of groups are different. And so this allows them to compare the mean more accurately. And what they found was there was a change from baseline in sleep efficiency. So the proportion of time patients were spending in bed asleep. And again, in the Lemborexant 5 and 10 group, that proportion was higher and statistically significant when compared to Zolpidem and placebo. In terms of wake after sleep onset, that relationship still remained to be true in that patients who were on Lemborexant 5 were having lesser amounts of minutes wake after they had fallen asleep. And this was again statistically significant compared to Zolpidem and placebo, and this was present in the second half of the night as well. In terms of the subjective components of this trial, when we look at the electronic sleep diaries, the results were actually not as clear as they were on polysomnography. So although there is a mean change in subjective sleep onset in both the Lemborexant 5 and 10 group when compared to placebo, you can see here that it is not as significant and not as different with quite a high standard deviation as seen in the first 7 nights compared to the end of the month. In terms of the percentage change in wake after sleep onset, it's interesting in that Zolpidem patients felt they had a greater proportion of change compared to Lemborexant 5, which was not something we saw in the polysomnography group on the previous slide. And in fact, patients felt they had the greatest amount of change at the end of the 1 month when compared to Lemborexant 5 and 10 milligram groups. there isn't too much information in the journal article given on treatment emergent adverse events. What we do see is that the vast majority of treatment emergent adverse events were in the Zolpidem group when compared to Lemborexant 5 and 10. And interestingly, we do see some treatment-related adverse events in the placebo group as well, so it's not really clear to me how they made that determination. There is, in the Zolpidem group, 8 severe treatment emergent adverse events. We're not given information on what those exactly are. And then the other thing I thought was interesting here is that in the Lemborexant 10 milligram group, there is a higher proportion of patients that experience somnolence and a higher proportion of urinary tract infections. And it's not clear to me if those are related or if there's a separate mechanism by which Lemborexant is leading to urinary tract infections. What we do know is all adverse events were transient and completely resolved. There was no deaths that occurred in the study. There were 4 participants who had fall, all in the Lemborexant 5 milligrams group, and none of it was believed to be related to the medication itself, as determined by the clinical investigators. And there was no clinically significant change when we looked at laboratory tests, vital signs, weights, or ECGs. And there was no evidence of suicidality. This was measured because there is some emerging evidence that orexins are important for mood regulation and feeling happy and reducing symptoms of depression. In terms of the ISI total scores, a clinically significant reduction in ISI is approximately 6 points. And we do see that in this study, they were able to achieve about an 8-point reduction in both the Zolpidem and the Lemborexant groups as well. There is interestingly a reduction in the placebo group as well of approximately 6 points in this study. So in terms of review of the results, what we know is that treatment with Lemborexant therapies leads to a greater improvement in both polysomnography-based sleep onset and sleep maintenance outcomes when compared to placebo and Zolpidem. The relationship is not as clear in the electronic sleep diaries, but we do see some evidence of improvement in sleep onset and maintenance, particularly when compared to placebo. Lemborexant therapy was generally well tolerated. There were some treatment emergent adverse events. We're not giving a lot of details on what those were, but they were quite minimal in the Lemborexant therapies as compared to the Zolpidem therapies. And self-rated severity of insomnia symptoms did improve by approximately 8 points. In terms of the critical approval, so was the assignment of patient randomized? Yes. Were the groups similar at the start of the trial? So you would hope that they were similar because they were randomized through a computer-generated software. But what would have been nice to see is that if we were given a bit more information in terms of comorbidities, number of medications, frailty, especially if we are going to apply this to a geriatric specific population. Aside from the allocated treatment, were groups treated equally? It's not really clear to me, primarily because even reading the protocol itself, it's not really mentioned how often these safety assessments were happening, how many clinical visits were arranged, how was compliance being monitored at all these different sites. So I'm not fully clear on that. So were the results relevant for our patient population? I would argue it was, but it should be noted the majority of patients were Caucasian and female. Is the treatment feasible? So yes, it is feasible, but there is a cost associated with it. And just looking at the website, about a 30-day supply of Lemborexant 10 milligrams is about $294. And will the potential benefits of the treatment outweigh potential harms? I argued yes, just generally understanding that the treatment was well tolerated. And if a patient is suffering from insomnia or if they're having a lot of sleep-related issues, then this may be a potential option to turn to. So that's it for my study. I'm happy to take questions.
Thank you, Rameez, for a wonderful presentation. Very clear, introducing new concepts, and the clarity of the outcomes was very well described. Barry has his hand up. Barry, would you like to read your? Go ahead, Barry.
Yeah, I have 2 questions. The one I put in is, even going back to a huge review article 10 years ago in the New England Journal, there's always been a discrepancy between what we get on polysomnography and what the patients feel is happening to them. And so my question there is, maybe we're measuring the wrong thing as far as patient satisfaction goes. And number two is a comment that the falls were not caused by the drug. I have yet to have a patient, even those who, when they stopped their medication, stopped falling, who said that the drug was causing their falls. So, I would be interesting to know who actually paid the investigator and that kind of thing, and what, because that is garbage as far as I'm concerned, that comment.
Yeah. I mean, one of the rationales that they argued for why the Zolpidem group felt they got better sleep is that it's a more sedating drug. So when they're waking up in the morning, are they still tired? And is that why they're not capturing the information correctly in their electronic diaries? But yeah, it is a good point for sure.
Great. Thank you. We have Gary. Go ahead.
So just to follow up on Barry's comment about garbage, Rameez, I'd like you to comment on the authorship of this paper and the potential conflicts of interest and how we should be considering that in terms of what I'd consider to be a pretty glowing conclusion from this paper.
Yeah. I mean, I introduced it right off the bat. I mean, this is a funded trial from a pharmaceutical company. And what I found interesting is that the data was specifically analyzed by their statisticians. So that definitely, there's an interest there in this company, obviously, to promote their medication. And so that has to be kind of taken kind of with a grain of salt. And so I am interested to see how research on this drug evolves and whether more sort of publicly kind of funded trials will come to light that replicate some of the results that we've seen here.
Yeah, I mean, I did find it quite unusual compared to a lot of other industry funded trials, is that the two primary authors who did the analyses and drafted the manuscript were employees, which always makes me have to think hard about it. To Barry's comment, I guess the question is, what's more relevant in terms of actual ultimate health outcomes? Is it the person's perception of their sleep, or is it the polysomnographic findings? Because that's important given the discrepancy in the paper. I'd argue that this is not a terribly representative sample of the people we typically look after. And it's quite concerning to see the insomnia side effect after a month, because as we know, particularly in our population, if people have more insomnia during the day, that could be a fall risk. But thank you very much. Nice presentation, Rameez.
Thank you.
Thank you. Shabir, I'll get to you in one moment. I'm just going to read the two comments in the chat box that appeared. Jesse Singh, is there any patients you would not use Lemborexant for, i.e. active depression? And Gabriel Chan writes, any comment on effects on dependency and cognitive function on long-term usage? I believe it was only a 1-month trial. So perhaps Rameez comment, and then we'll get to Shabir's last question.
Jesse, one of the subsequent trials I looked at Lemborexant analyzed kind of what happens to the patient's sleep when they're on this medication. And one of the things they found is there's a greater proportion of patients who experience REM sleep when they're on Lemborexant. And so I would argue that if a patient has a REM sleep behavioral disorder, then that would be the type of patient that you wouldn't necessarily want to use this medication on, because it may make that worse. And then the depression literature is still evolving. So personally, because there is that link between orexins and mood, I would be very hesitant to use it in patients who have active depression per se, but I'm not sure what the experience of other geriatricians is in that regard.
And any comment on the cognitive function or long-term use, or there is no data yet in post-marketing?
I think it's still evolving. Nothing that I came across personally. I think what is encouraging is that it was still effective at the 30-day mark, so that may give some semblance that it can be used over a period of time, but I haven't seen too much data on cognitive function and long-term usage.
And go ahead, Shabir, last question.
So great presentation, great questions and discussion, Rameez. I'll be very quick. In terms of the costs, so many of us use, reluctantly some of the Z drugs in our practice, such as Zopiclone and Zolpidem. And how do you compare their costs, if you know, to Lemborexant, which is about $10 a pill?
Can you tell me their cost? I don't know off the top of my head what the cost of Zolpidem is.
And that's okay. I think it's good for us to all know the cost,
Yeah.
but I think many of us don't. But
Yeah.
in Ontario, the Ministry of Health covers, to my knowledge, Zopiclone. It costs about
Yes.
50 cents a pill.
Okay.
They do not cover Zolpidem, which costs about $1 a pill. So Lemborexant is 10 times more expensive than Zolpidem, and Zolpidem is twice as expensive as Zopiclone, which is covered. So my follow-up question, are you aware of whether there's a difference in efficacy between Zolpidem, which they used in this study, versus
Yes.
Zopiclone?
I don't know the literature off the top of my head. I'm not sure if there's a difference. I actually
I'm
don't
not
have too much.
It's been a while since I read it. There've been some systematic reviews that I'm aware of, and I think the difference in WASO and time to sleep is on the difference of a couple of minutes between Zolpidem and Zopiclone. I don't think there's any convincing data that one is better than the other, but of course there are no head-to-head trials just for us to compare to. But yeah, great discussion. Very interesting drug.
What I will say, last point, the reason why they used Zolpidem in this study in particular is because they argue that trials that have looked at Zolpidem have shown that its efficacy lasts for the first 5 to 6 hours of sleep time. And so they were arguing that patients predominantly wake up in the second half of the sleep, and that's where Zolpidem is not as effective. And so they wanted to know whether Lemborexant would be an appropriate alternative in that regard.
I mean, in many of these drug studies, they will very carefully pick their comparator drug. So one has to be very cautious about that. But from my, and I'm not an expert, but from my review of the Z drug literature, Zolpidem is reasonable, and it's certainly not worse than Zopiclone, which is one reason why they might have picked it. But I don't think so from what I can read, but I can't claim expertise in that.
Yeah. Okay.
Great. Thank you very much again for the great presentation and great discussion. I have yet to see it. Perhaps in the chat box, if any of you out there have seen your patients taking Lemborexant, please add a comment in the chat box. For the sake of time, we will move on and extend a warm welcome to Dr. Sara Tomaszeski, who will be presenting at Journal Club for the first time. PGY4 resident with a keen interest in movement disorders, to present on cholinesterase inhibitors for gait, balance, and falls in Parkinson's disease, a meta-analysis. Over to you, Sara.
Thank you so much. So I'll just share my slides. Everyone, thank you so much for the introduction. So today I will be presenting a meta-analysis on cholinesterase inhibitors for gait, balance, and fall in Parkinson's disease. So I chose this topic, as Dr. Gandel said, because of my interest in movement disorders. So I hope I can make this topic just as interesting for you as it is for me. Before I get started, I would like to let you know that I have included some annexes at the end of the presentation with additional details for your interest. I will not be going through them today for the sake of time, but they will be available to you. So I have no conflicts of interest. This study was published in Nature's partner journal in November 2021 by researchers Chen, Huang, and Hong, based in Taiwan. They received funding from the Parkinson's Foundation, which is a nonprofit organization. Before we target the critical appraisal of the selected study, I will take some time to explain the pathogenesis of Parkinson's disease and Parkinson's disease dementia, the gait dysfunction in Parkinson's disease, the link between cognition and gait dysfunction, and finally, the role of cholinesterase inhibitors in Parkinson's disease. Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's. Some cardinal motor symptoms include tremors, rigidity, bradykinesia, gait disturbance, and postural instability. Unfortunately, gait disturbance does not respond very well to dopaminergic therapy. So gait disturbance and falls are substantial threats to the quality of life and mortality of individuals with Parkinson's disease. 60% of patients with Parkinson's disease report at least one fall per year. Recurrent fallers report an average of 21 falls with a very wide range from 4 to 68 falls per year. There are many specific Parkinson-related risk factors, such as rigidity, cognitive impairment, slow gait, and medication side effects, which can increase the risk of falls. There are also many countless generic risk factors common to older adults in general, such as different medical comorbidities, mood disorders, polypharmacy, and high-risk medications that we've all seen. Parkinson's disease is characterized by the loss of dopaminergic neurons in the substantia nigra pars compacta. as well as intracytoplasmic Lewy body inclusions consisting of aggregated alpha-synuclein and ubiquitin proteins. So this leads to presynaptic denervation of the nigrostriatal dopaminergic pathway, connecting the substantia nigra in the midbrain with the caudate nucleus and putamen in the forebrain. Here we have an example of PET imaging showing decreased activity in the striatum typical of Parkinson's disease. Denervation of this pathway is insufficient, however, to explain the Parkinsonian syndrome. It is only the tip of the iceberg. So there are many other structures involved. In addition to dopamine pathways, there are important cholinergic pathways responsible for the pathogenesis of Parkinson's disease. We have the basal forebrain cholinergic neurons labeled in red with the key nucleus basalis of Maynard, which projects to the cerebral cortex, thalamus, hippocampus, and amygdala. There is also the pedunculopontine nucleus in blue, which I will refer to as PPN. It is highly interconnected with the basal ganglia and has important projections to the thalamus and spinal cord. It is well recognized that the degeneration of the nucleus basalis of Maynard is associated with Parkinson's dementia, which may in turn be responsible for worse gait performance. On the other hand, the PPN and its decreased thalamic projections contribute to postural instability and fall risk in Parkinson's disease. The cholinergic deficits in Parkinson's disease dementia are oftentimes more pronounced than the ones seen in Alzheimer's. This effect is even seen with Parkinson's disease without cognitive impairment, except for the hippocampus and a few other areas that are typically more affected in Alzheimer's disease. This is a chart showing % reduction in brain cholinesterase activity based on PET imaging. This reduction is more pronounced in patients with Parkinson's because there is less acetylcholine available for the cholinesterases to break down. Another important paradigm shift was the Braak hypothesis established in 2003. It was postulated that Lewy body pathology travels through the CNS and affects particular neurological structures over time. In early stages, the medulla and olfactory bulb can be targeted, causing hyposmia and REM sleep behavior disorder. In stages 3 and 4, we noticed the onset of classic motor symptoms due to Lewy bodies in the substantia nigra and other midbrain and forebrain structures. Finally, in advanced stages, the cerebral cortex is affected, leading to Parkinson's disease dementia. So now that we have established the complex pathogenesis of Parkinson's, I will take some time to describe why patients with Parkinson's disease walk the way they do, focusing on gait mechanics. So we have all seen the typical patient with shuffling gait, freezing, decreased arm swing, and postural instability. And most of the explanations in the next slides come from an interesting literature review by Smulders from 2016. So bradykinesia can be seen in the upper body with a reduced arm swing and decreased range of motion of the trunk. In the lower body, gait speed is decreased, primarily due to short steps rather than slow cadence, which means number of steps in a given time. So in fact, Parkinson's disease patients are able to increase the number of steps to partially compensate for their small step length. So quick note on terminology, stride length represents heel to heel distance of the same foot, and step length represents heel to heel distance of contralateral feet. Patients with Parkinson's disease usually lose the ability to regulate the stride to stride fluctuations while walking. This is shown in the diagram on the slide, in contrast to a normal gait with equal length and duration of each stride. This is important because increased stride time variability is related to increased fall risk in Parkinson's disease. Short steps also lead to higher double support time with both feet on the floor, and this translates into the classic shuffling gait of Parkinson's disease. This executive syndrome can further worsen postural instability when concurrent motor and cognitive demands compete for limited attention. Gait initiation is a difficult concept. So in normal patients, the center of pressure actually first moves posteriorly towards the stepping foot, so that once you release that foot off the ground, it allows to accelerate the center of mass forward onto the support foot and therefore promote gait initiation and acceleration. Patients with Parkinson's disease have decreased anticipatory postural adjustments when initiating a step. They have a reduced force with which they lift their foot off the ground, leading to a smaller weight shift forward. This explains the hesitation in step execution and shorter first step. The speed of turning in Parkinson's disease is primarily related to the axial tone in the neck. So rather than turning sequentially, first with the eyes, then the head, the trunk, and finally the feet, patients with Parkinson's disease have simultaneous eye, head, trunk, and leg movements, leading to jerky steps and extra steps while turning. Finally, we have the most notorious form of gait dysfunction in Parkinson's disease, known as freezing of gait, where patients have the subjective feeling their feet are glued to the ground. Patients with freezing episodes walk more slowly, with shorter stride lengths and greater stride variability, and this is typically seen in more advanced disease stage. So what is the link between cognition and gait? Cognitive impairment can worsen gait through executive dysfunction and decreased attention. This is best seen with dual task walking tests when patients are asked to walk while performing a cognitive task. These patients tend to have low gait speed, increased gait variability, and poor coordination and balance. On the other hand, gait dysfunction, specifically gait variability, can be seen as a predictor of cognitive decline in Parkinson's disease. In a 4-year prospective cohort study of 90 patients with Parkinson's disease by Bian in 2018, it was shown that mean MCI-free survival of patients with high gait variability was 12% shorter than that of the mid to low group. Evidence for cholinesterase inhibitors is very, very well established in the treatment of dementia, such as Alzheimer's and vascular dementia. With respect to Parkinson's disease dementia, only rivastigmine was shown to provide a significant evidence-based therapeutic effect. Few studies have investigated the impact of cholinesterase inhibitors on gait, balance, and fall. Most were small scale, providing low evidence for benefits. So this brings us back to our study of interest. Shen and his team hypothesized that central acting cholinesterase inhibitors enhance brain cholinergic activity, modulating gait through cognitive and motor coordination aspects. They designed a study with the following inclusion criteria. They only included randomized controlled trials, which investigated the effects of cholinesterase inhibitors on either gait, balance, and/or fall. They included any type of cholinesterase inhibitor. Their study population focused on patients with idiopathic Parkinson's disease. The studies needed to have a clear description of the patient exclusion and inclusion criteria, the process of randomization, the method, the dose and duration of cholinesterase inhibitors, and a comprehensive assessment of gait, balance, and fall. The studies needed to be published in English prior to May 2021. They searched multiple databases, including PubMed, Embase, and Web of Science. The two primary outcomes were the effects of cholinesterase inhibitors on changes in gait speed and gait variability. The two secondary outcomes were changes in balance and fall. When more than one outcome, one assessment tool actually was used per given outcome in a single study, the more commonly used scale was selected for the meta-analysis. The Prisma flow diagram guided the selection process of studies. Baseline and outcome data were independently retrieved by 2 reviewers, and disagreements were then resolved by a 3rd reviewer. Initially, 336 articles were identified. Over 200 were removed due to duplications. Other reasons for exclusion included publications in languages other than English, lack of placebo control, and fall being listed as an adverse effect of cholinesterase inhibitor treatment rather than a major outcome. The 5 remaining eligible RCTs were published between 2010 and 2020. The inclusion criteria were quite variable. Only 2 studies included history of falls as an inclusion criteria, while we know that this is a #1 risk factor for recurrent falls. Chung included patients with falls or near falls twice or more per week, while Henderson recruited patients with at least 1 fall in the previous year. The sample sizes were small. The lower samples typically had a crossover design. There was a male to woman predominance of 2 to 1 in most studies. This reflects the distribution of Parkinson's disease in the general population. The average age was 70. Most studies included patients with moderate disease. However, the study by Lee had more patients in the early course of their disease. The average duration of illness is 5 years in the Lee study versus 7 to 10 in the other studies. And they looked at, in terms of the timeline of their disease, they assessed it based on the onset of motor symptoms. Patients had actually normal cognition in 4 out of the 5 studies, except for the study by Lee, which studied patients with mild cognitive impairment and dementia specifically. Types of cholinesterase inhibitors were varied, and doses and treatment durations as well. Only the study by Henderson included all primary and secondary outcomes of interest within the same study. To perform the meta-analyses, the Review Manager software tool from the Cochrane collaboration was used to quantitatively synthesize the data. The effect sizes of continuous outcomes were reported as the standardized mean difference, which refers to the difference in mean outcome between groups divided by the standard deviation in outcome across participants. Statistical heterogeneity across the studies was assessed using the I-square statistic and chi-square. Studies with increased heterogeneity were not excluded from the meta-analysis, but reported as limitations. It is important to mention that not all of the 5 chosen RCTs included all 4 of the outcomes of interest, and so the studies had to be further subdivided to address each of the outcomes individually. The risk of bias was assessed by 2 reviewers and 1 extra one in case of conflict using the revised risk of bias from Cochrane collaboration. 5 domains were assessed, but unfortunately some statements were vague, saying some concern for the adequacy of randomization rather than specifying the degree of concern more precisely. Also, no reasons to support each decision were included. Something that was not mentioned in this table was the fact that there was some missing data for gait variability in 4 cases in the placebo group in the Henderson Respond trial due to technical issues with sensors. Thankfully, they did adjust for the missing data and provided adjusted results as well. In terms of study results, cholinesterase inhibitors did not significantly increase gait speed in patients with Parkinson's disease. Cholinesterase inhibitors, however, did have a significant beneficial effect on step or stride variability during the single task without cognitive distraction. The heterogeneity of this analysis was moderate but non-significant. As a reminder, the I-square statistic describes the percentage of variation across studies that is due to heterogeneity rather than chance alone. Studies by Mancini and Stewart only demonstrated improving trends, but on the other end, in the trial by Henderson, there was a significant decrease in step time variability by 28% in normal walking and 21% in simple dual task. However, as I mentioned earlier, when adjusting for some missing data in the placebo group due to technical issues, the results were no longer significant in the simple dual task. There are a few potential reasons as to why the patient's step variability did not improve significantly when challenged with simultaneous cognitive tasks. This is potentially due to the fact that the study included only patients with normal cognition. So we wonder if a more pronounced effect would be seen in patients with cognitive impairment. Cholinesterase inhibitors conferred trending but non-significant beneficial effects on balance. The heterogeneity of this analysis was quite high, potentially due to different baseline characteristics. So for instance, in the study by Mancini, 38% of patients had freezing of gait, a severe form of gait dysfunction. The study by Chung did not even comment on freezing of gait at all. The study by Chung also showed a positive trend with the activities balance confidence scale. However, when they used the Berg balance scale, they obtained a negative trend. For the purpose of the meta-analysis, the ABC scale was selected on the basis of the argument that it is more commonly used. The Henderson study also included a measure of balance using the controlled leaning balance tool. However, they only reported their outcomes in categories such as low, medium, and high, which made it impossible to include it in this quantitative meta-analysis. Cholinesterase inhibitors conferred trending but non-significant benefits on fall reduction. The heterogeneity of this particular analysis was very high due to highly variable numbers of falls per year. In the study by Henderson particularly, there was a significant absolute risk reduction of 45% in the rate of falls per month with rivastigmine. In the study by Lee, there was also a significant difference in incidence of falls in patients with cognitive impairment specifically. Finally, the fall outcomes in the study by Chung had to be excluded from the quantitative analysis since they did not provide details about their baseline number of falls. So this brings us to sort of an overview of our results. We know that dopamine medications can target some of the classic motor symptoms of Parkinson's disease, including rigidity, bradykinesia, and short steps. We now establish the potential role for cholinesterase inhibitors for targeting the gait variability by activating the PPN nucleus in the brainstem. So now we will focus on the critical appraisal of our study. Did this study address a clearly focused question? I would say yes. Is it likely that important and relevant studies were missed? Overall, no. The search included major databases. The search strategy used appropriate controlled vocabulary terms, And there was a very wide time frame. They considered all available studies prior to May 2021. Studies, however, were limited to English, and they did not manually search reference lists, which could have led to more articles being selected. Were the criteria used to select articles for inclusion overall appropriate? I would say yes. They were defined in advance. Some limitations, specifically when it comes to exclusion criteria, was the fact that they were only defined during the study selection process, and different studies were excluded from the analyses of the individual study outcomes, as I've shown you, for various reasons that were established during the data extraction process. So ideally, they could have done a scoping review to sort of help determine the exclusion criteria in advance. Were the results similar from study to study? Yes and no, depending on the outcome assessed. So the I-square showed low heterogeneity for different gait parameters, but high heterogeneity in balance and fall data. Were the included studies sufficiently valid for the type of questions asked? So on one end, the methodological quality of each study was assessed appropriately using 2 authors rating the risk of bias and a 3rd author for disagreements. However, even when the heterogeneity was deemed high, it was still included and analyzed in the study. There was also some specific concerns with validity in the Henderson Respond trial. The study used a single sensor on the belt rather than multiple sensors to measure gait variability, and this was proven in a different study to be of poor to moderate validity. They also did a post hoc analysis to assess for the quality of blinding and noted that more subjects in the rivastigmine group guessed their allocation correctly, more than what would be expected by chance. And they explained that this is possibly due to the expected and experienced side effects in this population. Are the results generalizable and applicable to my patients? Yes. The mean age in the study was 70, which is sort of representative of our general population in geriatrics. Falls and gait dysfunction are a common presentation in patients with Parkinson's disease in different contexts we work in. However, the recruited Parkinson's disease patients had to be able to walk independently, and in most studies without any walking aid, which excluded those with the most severe gait disturbance and highest risk of fall. The different studies did not consistently examine the interactions of key comorbidities and polypharmacy on the risks of fall. It was quite inconsistent across studies. There was also no data on patient ethnicities, therefore limiting generalizability. So one of the studies was based from China, 1 from the UK, and 3 from the US. But again, the distribution of ethnicities is unknown. So what are the strengths? So first of all, the study analyzed multiple gait parameters, balance, and fall risk, all within one. It highlighted the need for more studies for cholinesterase inhibitors for gait improvement in Parkinson's disease. The time frame for the study search was wide and included all studies prior to May 2021. And the fact that they have included RCTs over other types of studies is also another strength. In terms of limitations, there are quite a few. The sample sizes were small and few studies included in each outcome analysis, as you've seen, either 2 or 3. The included studies were short in duration, so typically a few weeks and maximally up to a month, and there was lack of long-term follow-up. The falls were not objectively measured. They were self-reported, also introducing potential for recall bias, but this was limited by near real-time reporting using diaries and other tools. Many factors influencing fall risk were not accounted for, introducing potential confounders, and there was a lack of baseline data on many comorbidities in certain studies. There were some potential conflicts of interest as well. So the meta-analysis itself received a grant from Parkinson's Foundation. However, it is a nonprofit organization, so the risk of conflict is certainly quite low. But the study by Chung included within the meta-analysis was funded by Pfizer. They did specify that Pfizer did not participate in the design and did not overlook the results of the study. In the study by Mancini, one author had competing commercial interests in the result. However, it ended up being a negative study, which is a bit more reassuring. 3 of the included studies shared 2 same investigators. All 3 studies were done at the Oregon Health and Society University in different years. So this can cause potential re-recruitment of the same patients from previous studies, leading to overrepresentation. There was also a lack of standardization of outcomes tools and timing of measurements, whether they were done during the off or on phase with respect to motor fluctuations. Although freezing of gait is the most notorious gait disturbance in Parkinson's disease, only one study by Chung assessed the effect of cholinesterase inhibitors on freezing, which demonstrated no significant benefit. Only one study evaluated the impact of cholinesterase inhibitors on fall reduction in patients with cognitive impairment. And this study, however, did not include a direct comparison to patients without cognitive impairment. So given the known benefits of cholinesterase inhibitors on cognition, we wonder whether cholinesterase inhibitors confer an incrementally larger benefit for gait improvement in patients with cognitive impairment versus without. There were some concerns with regards to randomization, and there was a technical error in the Henderson study leading to simple randomization. There was also no table with baseline characteristics and p-values provided in one study by Chung. They only include a short list with key features. The increased heterogeneity for certain outcomes can be explained by the lack of uniform patient selection between RCTs when it comes to falls and other factors, and the fact also that they merge results of various types of cholinesterase inhibitors. So there remain many unanswered questions when it comes to the benefit of cholinesterase inhibitors on gait variability. Is it a class effect? Is it a drug effect? Dose-dependent effect? What is the optimal duration of treatment? What is the onset and duration of the clinical effect? Many, many questions. It is interesting that only the study by Henderson, which used rivastigmine, showed significant improvements with regards to step time variability in normal walking. The studies by Mancini and Stewart using donepezil only showed improving trends, potentially signaling that the benefit is more pronounced with rivastigmine use. And when we look at the mechanism of action of different anticholinesterase inhibitors, rivastigmine's inhibition of both butyrylcholinesterase and acetylcholinesterase explains its difference from donepezil, which only inhibits acetylcholinesterase. So this explains the larger availability of acetylcholine at neural synapses with rivastigmine use. So overall, despite the study limitations, we recognize that cholinesterase inhibitors may improve gait variability and provide trending benefits for balance and fall prevention. And as we've noticed, there was no difference in gait speed. Considering the tolerability and cognitive benefits, rivastigmine is the preferred treatment of choice with dual benefits for people with Parkinson's disease. For now, rivastigmine is only officially approved in Parkinson's disease dementia. It is sometimes used off-label in Parkinson's disease MCI for the potential gait benefits. Despite the fact that the current meta-analyses primarily study patients with normal cognition, rivastigmine is not yet approved for the sole purpose of gait improvement in Parkinson's disease. So we certainly need more data to support this finding. There is currently an open trial called CHIEF-PD. It is a phase 3 randomized double-blind placebo-controlled trial of rivastigmine for fall prevention in Parkinson's disease. It will be interesting to see what the results will show. So thank you very much for your attention, and I welcome any questions.
Thank you very much, Sara. That quite a excellent first presentation at Journal Club. I echo Barry's comments in the chat box. Fabulous background presentation, and all of your slides and the detailed critical appraisal was wonderful. A comment from Shabir just before we get to Gary's question that was posted in the chat box. Method of assessing falls, self-report and diary reporting are commonly considered gold standards in outpatient community-based falls trials. So I would not be too critical of that approach as long as done in a reasonable time frame to minimize recall bias. So a comment on that outcome. And Gary, please go ahead.
Sara, that was an outstanding presentation. So thank you for that. First, I'd just like to make a comment that many disease foundations receive the majority of their funding from the pharmaceutical industry. And in fact, many suggest that the pharmaceutical industry uses these foundations as a mechanism to essentially launder their bias through what appears to be a nonprofit organization. So I just want to make sure that you have an awareness of that there, because there has been a fair amount of controversy with some of these disease foundations. I guess what struck me, I didn't read it in the detail that you have, is the notion of heterogeneity. It seems like a whole bunch of studies, some have cognitive impairment, some don't, some required people to have falls and others didn't, etc. So, I'm always concerned, the benefits of meta-analysis can be wonderful when you're combining a whole bunch of very similar things. They can lead to some very bad conclusions when you're combining a whole bunch of different things. But the question I have for you, I'm curious, having looked at this in great detail, might you think that we could see the most benefit from cholinesterase inhibitors in people with Parkinson's and cognitive impairment, which would probably suggest that executive dysfunction is a particular problem and possible a contributing factor to their gait problems.
Mm-hmm. Yes, that's exactly what I think, specifically when it comes to sort of the different tasks that they ask patients to perform, either like simple walking, then with cognitive distraction, because they all had normal cognition and they selected patients that way to kind of isolate the impact of cognition and solely focus on gait improvement, then that the benefit was not so pronounced. But I wonder whether with cognitive impairment, they would have benefited more, since we do know that in Parkinson's disease dementia specifically, there are even more pronounced cholinergic deficits. So if you sort of replace them with the use of cholinesterase inhibitors, the idea would be that it would be more pronounced. And I actually spoke to some experts as well in movement disorders, and they certainly have seen improvements more pronounced in the Parkinson's disease dementia population, but they certainly also use it in mild cognitive impairment.
Yeah, it would be nice to see some detailed cognitive testing as a baseline with these patients, because even absent certainly dementia, executive dysfunction is, as you know, very common in people with Parkinsonian syndromes, and be very interesting to correlate the executive dysfunction on cognitive testing with their potential response to cholinesterase inhibitors.
Absolutely.
Thank you very much. Murray and Thiru both congratulate you on an excellent presentation, Sara. I might offer a comment that I know some anticholinergics are used, particularly in younger individuals, to attempt to remedy tremor. And I wonder if that was considered in these studies, anticholinergic use in these patients.
So in most studies, they had excluded patients who were taking anticholinergic medications. I actually can show you in the annex where I outline. So they basically, so 3 of the 5 studies excluded patients for the use of drugs with anticholinergic properties, and 2 studies specifically excluded those that had an indication for Parkinsonism, urinary urgency, and TCAs for depression.
Great, thank you. Any other questions or comments for Sara? If not, I will say what a wonderful way to resume Journal Club with 2 excellent presentations. Very impressive. By way of announcements, please remember to complete your Journal Club evaluations, which should have arrived to your email inbox already. And I look forward to seeing everyone, if not at Journal Club next month, at CGS in the beginning of April. It was nice to see everyone. Thank you, Sara and Rameez, for 2 wonderful presentations. Have a good day.